Today our topic is supraventricular tachycardia. This is any tachycardic rhythm originating above the ventricular tissue. Paroxysmal supraventricular tachycardia is a rapid rhythm of the heart which involves in the accessory pathway. Symptoms: there will be the pounding chest, shortness of breath, chest pain, rapid breathing, dizziness, loss of consciousness, numbness of the various body parts. Types: SVT from the sino-arterial source, inappropriate sinus tachycardia, sinus arterial node, reentrant tachycardia. SVT from an arterial source. This is a ectopic, which is a unifocal atrial tachycardia, multifocal atrial tachycardia, atrial fibrillation with a rapid ventricular response, atrial flutter with a rapid ventricular response. SVT from the atrioventricular source, junctional tachycardia, AV nodal recurrent tachycardia or the junctional reciprocating tachycardia, AV recurrent tachycardia, visible or the consent, including the Wolff-Parkinson-White syndrome, junctional ectopic tachycardia. Sinus tachycardia. This is the physiological or the appropriate when a reasonable stimulus such as the catecholamine surge associated with the fright, stress or the physical activity provokes a tachycardia. It is distinguished by the presentation identical to the normal sinus rhythm except for its fast state, which is greater than 100 beats per minute in adults. Caused by the Rentary circuit localized to the AC node, resulting in the normal morphology P wave that falls before the regular narrow QRS complex. It is therefore impossible to distinguish on the ECG from the physiological sinus tachycardia unless the sudden onset is observed for the recorded on Holter monitor. It may sometimes be distinguished by its prompt response to the vehicle maneuvers. Ectopic unifocal atrial tachycardia resulted from the one ectopic focus within the atria, distinguished by the consistent P wave of abnormal morphology that falls before the narrow regular QRS complex. Multifocal tachycardia resulted from at least 3 ectopic foci within the atria, distinguished by the P waves of at least 3 different morphologies that all fall before the irregular narrow QRS complex. Atrial fibrillation, not in itself a tachycardia, but when it is associated with the rapid ventricular response greater than 100 beats per minute, it becomes a tachycardia. Atrial fibrillation is characteristically an irregular rhythm, both in its atrial and the ventricular depolarization. It is distinguished by the fibrillatory P waves that at some point in the choice stimulate a response from the ventricles in the form of irregular narrow QRS complexes. Atrial flutter caused by the re-entry rhythm in the atria with a regular rate of about 300 beats per minute. On the ECG, this appears as a line of sawtooth P waves. The AV node will not usually conduct such as a fast state, so the PQRS usually involves the 2:1 or 4:1 block pattern. Because the ratio of the P to QRS is usually consistent, a flutter is often regular in comparison to its irregular counterpart. A fibrillar atrial flutter is also not necessarily to tachycardia unless the AV node permits a ventricular response greater than 100 beats per minute. AV nodal recurrent tachycardia, junctional reciprocating tachycardia. Since the atrioventricular junction AV junction encloses the AV node, it involves a Rentry circuit formed just next to or within the AV node itself. The circuit most often involves the two tiny pathways, one faster than the other, within the AV node. Because the AV node is immediately between the atria and the ventricle, the re-entry circuit often stimulates both, meaning that the retrogradely conducted P wave is buried within or occurs just after the regular narrow QRS complexes. Atrioventricular recurrent tachycardia, circus movement tachycardia, also results from the Rentry circuit, although one physically much larger than the AVNRT. One portion of the circuit is usually the AV node and the other an abnormal accessory pathway from the atria to the ventricle, Wolff-Parkinson-White syndrome. This is relatively common abnormality with an accessory pathway, the bundle of Kent, closing the AV valvular ring. In orthodromic AVRT, atrial impulses are conducted down through the AV node and retrogradely re-enter the atrium via the accessory pathway. The distinguishing characteristics of the orthodromic AVRT can therefore be a P wave that follows each of its regular narrow QRS complexes due to the retrograde conduction. Antidromic AV artery. Arterial impulses are conducted down through the accessory pathway and re-enter the atrium retrogradely via the AV node, because the accessory pathway initiates the conduction in the ventricle outside the bundle of His. The QRS complex in antidromic AV artery is often wider than usual with the delta wave.